Well, I was just sort of looking for a more effective or the most effective minimally invasive and microinvasive functional procedure. Something that balances good safety profile with efficacy, essentially. I mean, it's just a statistics game. If you can treat 3 or 4 clock hours and you're assuming that that's where you can reestablish aqueous outflow, when you assume that, sometimes you're wrong. Sometimes treating 4 clock hours when you could treat 12 clock hours, you're just on a percentage basis, you're treating less, doing less than you could potentially do. Canaloplasty combines very well with cataract surgery as well. So you really can do it in any setting, whereas at least in the United States, from a regulatory perspective, not all of the MIGS procedures can be done with that degree of flexibility. I always tell patients, if you have 2 problems, address 2 of them. Don't address one and just save the other one for later, or say, we'll just do laser drops or something. Address both. You're in the OR, you've already mitigated the risk. You already crossed that line of doing intraocular surgery, so combine it. Do as much as you can in that one stop inside of the patient's eye as you possibly can. And so if you can leave some or most of the eye anatomically intact, the aqueous outflow system intact, but do just enough to give it a kickstart, to reestablish better or normal aqueous outflow, then I think that's a better approach. Canaloplasty is kind of one of the just most minimally invasive procedures. You're really leaving the anatomical structures of the eye kind of almost as they were, as much as possible. It's just stretching. All that viscoelastic then dissolves and is gone. And then at the end of that, ideally what you're left with is a re-expanded outflow system that's going to hopefully regain some of that youthful function that it once had. You're talking about success, that's, you sort of have to define success, and that's lowering pressure to target range, a safe range, but then doing so in such a way that doesn't affect the patient's quality of life. Maybe we can reduce or eliminate some eye drops. So patient selection and communication, when you're deciding to go forward with canaloplasty as part of your surgical plan, I think those are the most important things. One of the best features that I like, but I think lots of comprehensive cataract surgeons are going to appreciate also, is just usability. So if you have a great device, but it is difficult to use, or the learning curve is a little steeper than you might otherwise want, the adoption of that device isn't going to be as good as you want. So the packaging of the new microcatheter within the deployable cannula, the surgeon can do that with one hand versus previously having to manipulate microforceps. Not every surgeon is comfortable with or proficient at using intraocular microforceps to manipulate a catheter that needs to be handled, with care. So taking that factor out of the equation and putting it, neatly packaged within a cannula that can just simply deploy that microcatheter in the direction you need to go in your stum's canal, I think is going to increase adoption and utilization of the device. I did lots of the old way, and I'm doing lots of the new way now, and it's just faster.